Our next speaker is Adam Carrico. We proudly claim Adam as one of our own alumni. He completed 2 postdoctoral fellowships at UCSF, one in health psychology and the other in reproductive infectious disease. Adam joined the faculty in 2010 and currently serves as assistant professor of community health systems in the School of Nursing, where he is developing and testing psychological interventions designed to optimize the effectiveness of HIV treatment in prevention, as prevention with HIV-infected, methamphetamine-using men who have sex with men. The title of his talk today is The Intertwining Epidemics of Substance Use and HIV/AIDS. Adam.
Thank you. It's great to be here and to present on our HIV/AIDS enterprise at UCSF. I really was honored to be asked to present in that I thought about probably 30 faculty that would do a better job than I would. So you're stuck with me. But really we stand on the shoulders of so many scientists at UCSF that have waged kind of dramatic responses against the epidemic to try and stem the tide and hopefully bring it to a close. And it's an exciting time to be talking about HIV and AIDS because we're really at a turning point, and some might even say an inflection point in the epidemic. We know that we have the tools necessary to end the epidemic and essentially eliminate or substantially mitigate community-level transmission. And those tools are ones that are known well to us, antiretroviral medications. Recent groundbreaking results from HPTN-052, a randomized controlled trial, demonstrate that early HIV treatment, treating people at a higher CD4 cell count before their immune system gets even further degraded, is good for their own health. It optimizes their health outcomes, leads to fewer opportunistic infections, and so forth. But there's a double benefit. We know that treating people early leads to a 96% reduction in onward HIV transmission rates. And these are genotypically linked transmissions with their uninfected sexual partners. So literally, HIV treatment is HIV prevention. We're seeing these worlds collide in synergistic and exciting ways. And there's a renewed sense of optimism that we can really achieve an AIDS-free generation. So I'm really proud to have my work be part of that. And part of the enterprise in HIV/AIDS research here at UCSF. But there are problems left to solve. We know that HIV-positive persons have prevalent psychiatric comorbidities like depression, bipolar disorder, and substance use disorders. These complicate the management of HIV/AIDS in multiple ways across the entire cascade, which you see some of the indicators here on my slide. So my work focuses extensively on substance use disorders as co-occurring chronic conditions that impact HIV disease management and ultimately health outcomes. And we hope by documenting these disparities, we can identify ways to develop new treatments that target substance use as a driver of the HIV/AIDS epidemics. So poorer health outcomes and onward transmission among HIV-positive substance users. So work that I've done here at UCSF in collaboration with, with Elise Riley and David Bangsberg, looked at a cohort of homeless and marginally housed HIV-positive persons. And we know that this population experiences important structural barriers to optimizing their health, street homelessness, food insecurity, and so forth. But what we did was look at the psychiatric factors. And we found that those that screened positive for a stimulant use disorder were 71% less likely to currently be taking antiretrovirals. And this was even at a level where their immune systems absolutely required treatment. So the problem here is twofold. One is access. We know that providers have implicit biases around prescribing antiretrovirals to substance users. They're less likely to say they would give someone ART, antiretroviral treatment, even at a CD4 count that qualifies for AIDS. We also know that the problem is utilization. Substance users have comorbid psychiatric conditions like PTSD and bipolar disorder, as well as chaotic lifestyles that drive them away from treatment and lead to poor engagement. So the next piece that we've kind of looked at in my program of research is adherence. Once people get access to treatment, how well are they doing? And this was with Doctors Mallory Johnson and Steve Marin as part of the NIMH Healthy Living Project. And we found overall that those that use stimulants, cocaine, crack, or methamphetamine, 2 or 3 times a month or more, had a 2-fold greater rate, or prevalence rather, of non-adherence to their antiretrovirals. So they reported taking less than 90% of their prescribed medication doses. We looked over the entire 25-month follow-up and found even more interesting disparities in HIV disease management. So people that use stimulants weekly or more were 2.5 times more likely to stop and restart their medications. We know that this is a particularly detrimental pattern. One of the major randomized controlled trials in HIV showed us this, that when you stop treatment, you develop genotypic resistance, you blow out that medication, and it may be less effective when you restart it again. It also contributes to the transmission of community-resistant viral load, right? So again, implications for both treatment and prevention. So it's not surprising, given these HIV, or difficulties with HIV disease management, that we see substantially elevated viral load in those that use stimulants. In the NIMH Healthy Living Project, again, we saw 137% higher viral load, the amount of virus in someone's blood over the 25-month follow-up. And there's a lot of evidence that there's a dose-response relationship between viral load and poor health outcomes, but also transmission rates, right? So again, treatment and prevention are relevant here. And those increases in viral load, or that elevated viral load, was mediated or explained by non-adherence and this pattern of stopping and restarting treatment. So I'm sure that some people in the audience are saying, what about the clinical implications of this? And I was asking myself that question as well. We know that viral load is a surrogate clinical marker, and I was really interested in health outcomes. In collaboration with investigators with the multi-center AIDS cohort study, we examined this question. The multi-center AIDS cohort is a cohort of gay and bisexual men, as well as other men who have sex with men in the United States, both HIV positive and HIV negative. So with the MAX investigators, we were able to look at starting antiretroviral therapy as the origin. We wanted to take access, utilization out of that equation and say, once people start their medications, what do their health outcomes look like if they're stimulant users versus not? And overall, we found some really reassuring news that mortality rates don't differ by stimulant use status. Even when you look at AIDS-related and non-AIDS-related mortality, there's no overall difference. At the same time, we find that those that use stimulants more frequently, at half or more of their study visits, had increased odds of progressing to AIDS, so developing an AIDS clinical condition or having severe suppression in their CD4 cell count, or dying. So there is some evidence that stimulant use contributes to impaired health outcomes in HIV disease, although not the overwhelmingly large effects that one might think, given the chaos that chronic stimulant use brings to one's disease management, which we've shown in prior work, of course. So overall, my work has really documented these disparities across the entire cascade of HIV disease management. We see poor utilization of antiretrovirals, difficulties with adherence and persistence with that medication regimen, and this leads to elevated viral load and greater clinical disease progression. So I've spent about 10 years trying to document some of these health disparities, and we're also actually doing something about it. We're trying to address methamphetamine use in particular as a driver of the HIV/AIDS epidemic by developing integrative behavioral treatments that target meth use and optimize the effectiveness of evidence-based approaches to drug treatment. We want to help people reduce or abstain from their stimulant use as a means of optimizing their health outcomes and reducing onward transmission rates. Thank you.